Assalamu alaikum, everyone. Is my voice clear?
Walaikum salam, ma'am. Yes, ma'am. Your voice is clear, ma'am.
Walaikum assalam. Yes, it's clear.
Thank you, Dr. Mustafa. It's really pleasant to see you here every day. And I see we have Dr. Yusra Hatif with us today. Is this your first session, Dr. Yusra?
I joined on Sunday as well. It's my second session today.
Oh, that's good. So let's proceed towards the pediatric diffuse gliomas. And I have reduced the quantity that we are going to cover in every session because we did have to cover quite a lot on Sunday, and a lot of people had found it harder to keep up with the pace. So I did decide to go a bit slower. And pediatric diffuse gliomas have two major categories. Ones are the low grades, and the other category is high grade. So, proceeding. So, the core idea behind today's session is going to be how the imaging is so deceptive in pediatric gliomas and how the biology is very, very distinct. And why diffuse doesn't mean malignant in pediatric neurosurgery, because you're going to see some pretty amazing cases. Moving on, is the radiology clear? Can
Yes,
somebody
ma'am.
please comment on these images? Any
Ma'am,
volunteers?
yes, ma'am. This is the picture shown in A is the axial cut of the diffusion weighted image, showing the hyper intense lesion at the uh, parieto-occipital junction, also involving the splenium of corpus callosum. Uh, the
Are
picture
you
shown in
sure A is diffusion weighted image?
T2 weighted image, ma'am.
It is T2.
T2. Picture shown in B is the coronal cut, showing the hypo-intense lesion with the hyper-intense rim at the uh, almost involving the whole right parietal lobe, along with the convexity, and also spread towards the splenium of corpus callosum and crossing the midline also. Picture shown in C is yes, ma'am.
Oh, okay, go on.
It is a T1 with contrast, which is showing the hypo-intense. The lesion don't taking contrast and not contrast enhancing. S- uh,
Okay, Dr. Mustafa, we can rest the individual radiology interpretation and tell me what is your impression of this pathology? What do you think this is?
it is a neoplastic lesion, ma'am.
Okay, what kind of neoplastic lesion?
Maybe it is a neuroepithelial tumor, ma'am, or choroid plexus papilloma or choroid plexus carcinoma.
Um, you are slightly going off the road. Can anybody else volunteer for this radiology, please? Do we have anyone else, or should I proceed?
Proceed, करने.
Okay, so this is T2, and this imaging is otherwise usually very typical for diffuse gliomas, right? We have all seen diffuse gliomas looking like this, hyperintense on T2, and very ill-defined, not exactly looking like a circumscribed lesion. There is very little perilesional edema, but there are two or three very peculiar things that are happening in this image, which is not usually a feature of gliomas that we see. Do you see these phloids here?
Yes, ma'am.
Do you people see my cursor? These are the phloids. These are vessels that are stretched like arrows here, and you can see these here as well. If you look very closely, or if you can follow my cursor, you can see that there is a pattern going on here. And these are vessels that are stretched like this. That's the first pattern. This is a specific radiologic sign that I will come to later on. But then there is another sign here. This lesion is hyperintense on T2, right? What is happening over here? This is flare. You can see that the periphery of this lesion is still hyperintense, but the center is hypointense. So this is T2 flare mismatch, right? So T2 flare mismatch was the typical radiology for
Astrocytoma?
exactly.
Grade
This
Astrocytoma.
2.
was the sorry.
Sorry, grade 2 astrocytoma.
Yeah, it was for grade 2 astrocytomas. So we have T2 flare mismatch going on here, and we also have this particular pattern of vessels, which is called fireworks sign. Fireworks sign and T2 flare mismatch is very particular for a certain type of pediatric glioma, and we are going to discuss it later. I have another radiology to share. What do you think is going on? In all of these images, there is a common theme. Anyone? Okay, let's go on. So in section A and B, you see that this is a T2 weighted image. This is hyperintense here. This is a flare image, and there is T2 flare mismatch. Again, a hyperintense periphery, and the center is hypointense. When we come to C and D, you can see that there is something similar going on. This is also going on here in the images below, E and F, and G and H. So I think the first set of images shows very clearly what actually T2 flare mismatch is. And remember, because this is a very particular sign for the tumor we are going to discuss today. And I think the same is going on here. Let's not stay stuck on the radiology because I don't have a lot of volunteers today. Or if anybody likes to volunteer, they can for this radiology.
Assalamualaikum. Can
Walaikum
I
salam,
start,
Dr.
madam?
Sana. Yeah, sure, you can.
Image number A is MRI T2 axial section showing an hyperintense lesion in the temporal lobe, right temporal lobe. And the image B is T1 with showing the hypointense lesion at the same level.
Image
And
B
the
or
other
image
one,
D?
B, madam, B.
Which one is T1?
Uh, uh, I think so. Uh, B,
Okay, and what do you think D is?
D, D. Uh, uh, Sorry, D is T1 and B is flare image.
Yeah.
G, G, sorry. And E is uh, sorry madam मैं E को नहीं
Okay,
कंफर्म कर
where
पा
do you
रही
think this lesion is? Okay, who
Next one.
was talking?
I'm talking.
Okay, where are you
Okay,
from?
I'm from Nigeria.
Okay, Dr. Kingsley, would you like to volunteer?
Yes, for the first image, that's image A, is a situated image showing a right medial temporal lesion that is hyperintense,
Mm-hmm.
aborting the midbrain. Then on the left, that's B, is a flare image showing a core of hyperintensity with margins of hyperintensity. That's T2 flare mismatch.
Yeah, exactly.
Then on
And
the image D looks like a DWI showing core of hyperintensity, but surrounding hyperintensity. So this looks like it doesn't have a restricted diffusion. But looking at E is a ADC map showing a hyperintense lesion. So showing there is no diffusion restriction. So there's a T2 flare mismatch without diffusion restriction. This lesion.
Okay, that's a brilliant take, Dr. Kingsley. Where do you think the lesion is located?
Yes, I am.
Okay, can you listen to me now? I was asking if you would be kind enough to comment now what the particular location of this lesion signifies. What is going to happen, how the patient is going to present.
Okay, the patient is going to present with likely going to present with a right-sided pupillary, that is anisocoral with right-sided pupillary dilatation, and then left hemi body weakness. May
Okay.
also present a visual problem owing to the location of the posterior cerebral artery.
Yes, but this is mesial temporal lobe.
May also present with a left-sided focal seizure.
Can someone else volunteer how this patient is going to present?
With seizures.
Exactly. My voice is still breaking up?
It's clear at either, madam, clear either.
Okay, somebody just commented in the chat box that it is still breaking, and I have just turned off my video because I think my internet speed is slow today and it was not taking up the cam as well. So, I had a good guess about the radiology not being very classic for today's cases, but this is mesial temporal lobe, and yes, there is some involvement or some abutting of the lateral ventricle temporal horns, but the horn in itself is not involved here. And since this is mesial temporal lobe, the patient is going to present mainly with epilepsy, right? So far we have understood two different radiology patterns, and one of them is T2 flare mismatch, which is very classically present here. The other is that these tumors are diffuse. There is not significant surrounding vasogenic or any sort of edema. There is not significant mass effect, but you also see this characteristic pattern, which is called fireworks sign. These vessels that are spread out like this, and moving on. So this patient was a 16 years old male with a 2-year history of worsening staring spells, which were focal seizures, recently becoming resistant to 2 anti-epileptic drugs. So can somebody volunteer that if you have received this patient in your clinic with history of seizures which are not responding to anti-epileptic drugs, how are you going to proceed? How are you going to approach this patient?
Hello, doctor. Can I try?
Yeah, sure.
Okay, hi. So to work up a drug-resistant epilepsy case, first I would like to know, okay, biochemical markers. So patient is already on anti-epileptics. I would like to know the compliance and also the TDM levels if it's available. Next, in order to work up, I would like a neurophysiological studies to do an EEG. And next, EEG. Then I would like to proceed with imaging. So in terms of imaging, depending on what I am thinking of, in the event I'm thinking of, if it's example in if it's a cortical lesion, if I'm thinking of something structural, I would order for MRI with contrast. But in terms of seeing any other non-structural lesion, I think I would request for a functional functional MRI, either a SPECT or a PET. So if still yeah, and also VEP, visual evoked potential study, to work up and to see the concordance of the seizures.
Okay.
Yeah.
So yes, you were right in the way that this was a medically refractory epilepsy. So we have to follow the refractory epilepsy protocol, right? But the goal is not just debulking the mass. We have to give patient freedom from the seizures as well. So the patient is already presenting to you with the MRI, they have the radiology, and they are telling you that this is a refractory epilepsy. Now you know that this is a tumor, and the patient is 16 years old. So if the biopsy report shows a diffuse astrocytoma, IDH wild type, what are you going to ask them to do?
If
Let me rephrase myself. This is a 16 years old patient with the imaging that we just discussed here. Okay? And this patient has a medically refractory epilepsy and they underwent surgery because we wanted to debulk the tumor. We also wanted to give patient a chance at freedom from seizures. And the biopsy came back telling us that this is a diffused astrocytoma, but this is IDH wild type. How common is IDH wild type astrocytoma in children?
Mm,
Dr.
not
Mustafa, are
very.
you going to volunteer or is your mic on?
Yes, ma'am. I'm listening, ma'am.
Okay, then
And
please turn off the mic if you're not talking. Okay, Dr.
I
Lalita,
think
So
what do you think?
I think wild type is quite rare. If I'm not, I don't know. I'm not too sure. But if it's surgical, I mean, if we only have a biopsy and the lesion is a surgical amenable lesion, so patient will have to go for we would need to attempt at least either a maximal safe resection or a gross total resection. Given the age, given the fact that the patient is a very young patient and the lifespan is longer, so we should try and attempt at maximal or either near total or gross total resection for this patient.
Yeah, that is right. But my question was for a 16 years old patient, if you receive a report of diffuse astrocytoma, IDH wild type, what are you going to ask your pathologist to do?
Um,
Okay, moving on.
so, yeah, sorry.
Ask them to run the pediatric panel.
Okay.
The pathologist had been running the adult glioma profile for a pediatric patient, 16 years old. Even though they look adults, 16, 17 years old, they still come in the pediatric age group, right? So we have to ask the pathologist to run the pediatric protocol, which is completely different from the adult molecular protocol, right?
Mm-hmm.
So this is how we are going to approach the patient. You were very right about a lot of things, Dr. Lalita. Phase one is obviously epilepsy workup. You have to go for EEG, for video monitoring. We have to identify the lesion. We have to identify the entire epileptogenic zone. The phase two is where we start the mapping. The functional MRI or diffusion tractography, we have to determine if GTR is even an option or if this is invading the eloquent regions, right? The phase three is where we have to plan the surgery.
Mm-hmm.
And for safe surgery in these patients, for maximum safe resection, we are going to need ECOG. ECOG is electrocorticography. This is just like EEG, but this is done during the surgery. EEG is done from a scalp, ECOG is done from directly on the cortex, and it works just like EEG, but it is a lot more precise, and it helps us in taking out all the epileptogenic areas perioperatively, right?
Yep.
Phase 4 is where we go for the molecular profiling. And why is that important? Because if you are getting a 16, 17 years old patient in your clinic and we are getting an IDH wild type on their biopsy, and the biopsy is also saying that this is diffuse astrocytoma, we are essentially handling them out a death sentence, right? For a
Yep.
very young patient. But the good news is, if the pathology, after being run the pediatric panel, comes back positive for MYB or MYBL1 alteration, the diagnosis and the prognosis completely changes. So, very interesting and sort of dramatically, moving on to diffuse astrocytoma, MYB or MYBL1-altered, which is IDH wild type, but it is low grade. These are WHO grade 1 tumors, surprise, surprise, and most commonly found in the cerebral hemispheres, particularly the temporal and the parietal lobes. Refractory seizures are the most common symptoms. Overall survival is excellent in these patients, approximately 95%. Gross total resection is the primary goal, you were right about that, and that is often curative. The difference between these tumors and the adult diffuse astrocytomas is that GTR is curative. It leads to a 5-year event-free survival of nearly 100%. And roughly 90% of these patients become seizure-free post-surgery, which was our secondary goal as well. So, I made this comparison table just to give you guys a very good idea about how different it is from the IDH mutant astrocytoma, even though this is also a diffuse astrocytoma. So pediatric diffuse astrocytoma is wild type, IDH. H3 status is also wild type. ATRX is retained, which expression was lost in IDH mutant astrocytomas, the adult variants. P53 is wild type here as well, and their malignant transformation is extremely, extremely rare, and that is why they have been given the status of WHO grade 1. And malignant dedifferentiation or malignant transformation is pretty common for these patients here, IDH mutant astrocytomas, and they do move on to grade 3 and grade 4. So, in this entire chart, the two things that should be remembered are IDH wild type in a young patient is not IDH mutant, the grade 4 astrocytoma. Moving on. We have already covered the radiology, even though I think some of you might need a little extra help regarding radiology. Should we get a separate section for radiology as well? Because it would eat up a lot of time if we end up getting hinged on the radiology separately. So
Much better,
are you
much
people
better idea.
that's a better idea because incorporating the entire radiology here and then also covering the topic is a bit difficult. But some of you might need some help. So leave me a message on the group about it and let's see if we can plan something. So on radiology, MRI T1, we already saw it. These are hypointense lesions. On T2, these are homogeneously hyperintense. And let's go back to the radiology slide. Oh, here it is. See, this is homogeneous hyperintense signals on T2, and there's T2 flare mismatch sign, which is very clear here. I think Dr. Burhan asked me, I'm not sure if he's here today or not, but this is a classic T2 flare mismatch sign. In adult patients, this leads more towards the diagnosis of astrocytomas, away from the oligodendrogliomas, right? But if you see this in a younger patient, this and sometimes very, very rarely we can see the fireworks sign as well, then this is likely pointing to the diffuse low-grade gliomas of pediatric origin. So what to do in a resource-limited setup? If I go back to the approach section, if you see this, most of this is limited to very well-equipped setups like video monitoring, like functional mapping, fMRI or DTI, ECOGs. We all know that a lot of this stuff is not available in the setups that we work in. I am not sure about the countries apart from Pakistan, but in Pakistan there are certain setups that are very well equipped. But most of the places where we work, the public sector tertiary care hospitals, I don't think any has even functional MRI. So, what to do in a resource-limited setup? The poor man's fMRI is anatomic mapping. That is why we have to be really, really diligent about how we learn the anatomy and how we clinically apply it. Because sulcal anatomy is the way to go here. Even if it's not going to be 100% accurate, it is still going to be a very good map of the brain. And on T2 and flare, we have to look for the blurring of the gray-white junction. In resource-limited areas, this is our best clue for the epileptogenic zone. And a lot of doctors, a lot of neurosurgeons who are working in resource-limited setups, If the lesion is a non-dominant anterior temporal lobe and the patient has refractory seizures, many surgeons skip mapping and perform a standard ATL. You just perform an anterior temporal lobectomy. But the patient that we discussed, it was not confined to the anterior temporal tip. So for that patient, we might need mapping. The focus should be on gross total resection. The more you can get out, the better. Because what happens if the GTR is not done, we are going to cover to that as well. So you have done a surgery, you have taken as much as you can, and a simple EEG 3 months postoperatively will tell you if your resection worked or not. But what happens in the cases of subtotal resection? For example, the tumor was involving the eloquent areas, and you were not able to get it out completely, but the pathology came positive for MYB alteration. That means this is a grade 1 tumor. What happens is there is a survival paradox. The impact of subtotal resection is going to manifest in two different ways. One will be oncological and one will be functional. How oncological? The first question that arises is, will this tumor grow? No, it won't, most likely. Or even if it grows, it will grow very slowly, and the chances of malignant progression is very, very low. But the more important question is functional. Will the seizures stop? So the survival paradox says that 5-year overall survival remains near 95 to 96%, even if you don't end up taking the complete tumor out. Event-free survival is an important metric because this is where the difference lies. If you have done GTR, the event-free survival is 100%. If you have done STR, then the event-free survival is only 56% at 5 years. So yes, the patient is going to live. The patient is going to end up surviving, but they will survive with epilepsy and quite a few drugs. STR is often considered a clinical failure because seizure freedom is rarely achieved if residual tumor remains, and the perilateral cortex is often highly epileptogenic in MYB-altered tumors. So, as I already told, malignant transformation is extremely, extremely rare, and in the cases where we have done subtotal resection, watchful waiting is the standard with serial imaging. We don't treat the imaging, we treat the patient. And that's a wrap for today. Any questions, any feedback?
Wonderful session, ma'am. Bundle of thanks.
Okay, let me know about the radiology section because I think we do need some work there. And I will upload today's recording. I have no idea how because it would be in two different sections. And I will upload the slides as well on a drive and share the link there. So you can go back to the presentations and take a good look at it and work on the radiology as well. Okay, everyone, this is a wrap. Thank you so much for being here. I really enjoyed
Thank you,
this,
ma'am.
and it's really nice talking to you every day. Have a good day.
Thank you,
Bundle
Doctor.
of thanks, ma'am.
Thank you.